Hello everyone. This presentation will be about autism in children. The slides are made by the Indian Academy of Pediatricians and is available online as a part of the 2015 to 16 IEP teaching module. Autism is not really much of a theory subject. It is more of a practical hands-on subject, and as far as dealing with autistic children is concerned, it is an art and science in itself. You can consider this presentation to be partially from a theoretical perspective and partially from an awareness perspective to parents as well as to the general public as well, though the bulk of it will be targeted at medical students as a part of their learning curriculum. We know that autism is a developmental disorder that appears within the first 3 years of life and is mainly because of the brain's affected development of social as well as communication skills. This definition was coined by Brittany Allen. But the term autism was first coined in the year 1943 by Leo Kanner, who was a child psychiatrist. Now, at that time, he observed that there were 11 children who demonstrated a profound lack of social engagement, who were unable to use language to communicate, and at the same time had obsessive need for the sameness. But there was a faulty postulation that autism was a result of difficulty in the parent-child relationship, which is proven to be not true in subsequent years. At present, we have recognized autism as a neurodevelopmental disorder as well as a neurobehavioral disorder and not a neurological disorder per se. And it has been recognized that autism is due to underlying disorder of brain development. Before moving on to what autism is per se, I would like to mention that April is Autism Awareness Month and April 2nd is Autism Awareness Day. And the theme for 2020 is Make It the Year of Kindness. So the goal for this year is to make it the year of kindness. So with that note, we'll move into a little bit more in detail about autism. It is a complex neurodevelopmental disorder characterized by qualitative impairment of social interaction, qualitative impairment in communication, as well as restricted, repetitive, stereotypical patterns of behavior, interest, and activities. To just name some few facts about it, autism is not a single disorder, but rather it is a spectrum. It is a wide spectrum and is associated with sensory hyposensitivity or hypersensitivity, often because of environmental factors. Symptoms vary between autistic children and do change over time, and there are no specific biological markers for autism. Now, this is important because many times parents do come forward asking for a specific test to help in labeling their child as autistic or not if someone has labeled the child as a suspect. But there is no specific biological marker for autism. The diagnosis is purely based on clinical findings, and it is to be ascertained based on the DSM-5 criteria, that is the Diagnostic and Statistical Manual for Mental Disorders 5 revised, that is the expansion of DSM-5. So the diagnosis is purely clinical based on the DSM-5 criteria, and the diagnosis is made after observing the child in several settings, not just one sitting. So that is important. It takes multiple sittings to diagnose a child as autistic and cannot be done in one visit alone. A bit about DSM-5 criteria in detail. The autism spectrum disorders include autism, Asperger's syndrome, child disintegrative disorder CDD, as well as PDD as well. So it's a collective diagnosis. It is a spectrum. It concentrates on certain required features like a social deficit or a communication deficit, and is associated with restricted repetitive patterns of behavior, interest, and activities. It is important to distinguish spectrum changes from non-spectrum developmental disabilities and to distinguish a developmental delay separately from this. And all of this collectively helps in improving the stability of the diagnosis. Now, as far as the social communication is concerned, there must be a deficit in the social emotional reciprocity, meaning the child will not be able to reciprocate the emotions which is shown. There will be a deficiency as far as the social milestones are concerned. There will be deficits in the non-verbal communicative behaviors. So the child will not be able to communicate by writing or scribbling. That is the earliest sign what we can expect. And there will also be deficiencies in developing and maintaining relationships as appropriate to the developmental level. So if we consider below the age group of 2 years, what would be expected is inability to first identify the mother, identify the father, identify the immediate family, and reciprocating the emotional bonding what is required between the mother, father, and the child. Now, about the restricted and repetitive behaviors, generally there will be at least 2 or more of the following: stereotyped or repetitive speech, motor movement, or use of objects. Now, for the use of objects, I will just demonstrate a very small example which will make it very clear. Yeah, as you can see in this image, it's an image of a child playing with a toy car. Now, for an age of 2 to 3 years, that is expected and normal. Now, we all know that a child learns from the environment, what is there at home, and from what the child sees on a day-to-day basis. So, when a child sees a car going from place A to place B and his parents driving the car, the child is able to understand that a car is used to go from place A to place B. So, if you give a toy car to the child understands that he is able to replicate playing with the car to get from point A to point B, which is a part of imaginative play, which is normal for that age of the child. Now, we know that it is common and quite natural for a child to imitate what is seen in the surroundings. So, if the child sees the mother cooking with the fry pan, with a pan and a utensil, if you give the same pan and utensil to the child can play with it. But quite rationally, nobody will allow the child to drive a car or sit in the driver's seat of the car. So he has to replicate that imagination through the toy. So the toy acts as an object of personification, and it is important to note that the child will play with the toy as a whole. Now, moving on with the same example of the toy car, I'll just zoom in so it's a bit more clear. In this image, the child is playing with a model SUV, which appears to have functional wheels as well as functional doors that open separately. Now, in this image, you can see that the child is playing with specifically the door of the car, meaning he's understood that there is a component of it which opens and closes. Now, it is quite normal for a child to be attracted to a specific function which is present. But supposing he doesn't play with the toy car as a whole and is only focused on opening or closing the door of this toy car, but not playing with the car as a whole. So I'll label this as A and this as B. What would be a normal response is to maybe play with the door, play with the wheels, and play with the car as a whole. If he is unable to play with the car as a whole but is continuously focused only on the door or only on the wheels on multiple sittings, that would become an alarming sign because he is not able to correlate with the function of the car as a whole, but specifically with one repetitive movement despite external stimuli. So that is what I am trying to say is abnormal. So I'm repeating myself. This example was merely given with the intention of focusing upon a repetitive movement. So with that good understanding of a repetitive movement based on the use of an object, apart from that, we can also consider excessive adherence to routines, highly restricted or fixated interests, like I mentioned the example of the door of the car, or hyper or hypo reactivity to sensory inputs or unusual sensory interest. When I say hyper or hypo reactivity, a good example of a sensory input is music. So we all know that a child would be interested in music to an extent. It will draw a certain interest, some songs more than others. An unusual interest towards music or an unusual aversion towards music, both are hyper and hyporeactivity respectively for the sensory input. Now, this DSM-5 criteria must be applied in early childhood, and collectively the symptoms together limit and impair everyday functioning. So, we go to each criteria in detail. The 4 criteria under social interaction are a lack of eye-to-eye gaze, a lack of facial impression, or just a lack of gestures while interacting, the failure to develop peer relationships as appropriate for age, and a lack of sharing interest with others, that is not pointing out objects, not bringing objects, or lacking social and emotional reciprocity. These 4 criteria come under impairment of social interaction. Now, moving on to impairment in communication, delayed development of speech. Now, an isolated speech delay is separate but should be a back of the mind diagnosis or differential in terms of diagnosing autism. the inability to initiate or sustain conversation, or stereotypical repetitive language or idiosyncratic language. Now, in the initial years, we all know that the vocabulary of a child is limited, but if the development of the vocabulary is not proportionate to what is expected for age, then it is to be considered as abnormal. And finally, this is often the point with which parents do bring their children forward. The inability for make-believe play or inability for social imitative play is definitely a red flag sign as far as diagnosis of autism is concerned. Now, moving on to repetitive behaviors, like the example what I mentioned of the car, we can consider that example as a very simple example to understand this. Stereotypical restricted patterns of interest, abnormal in intensity or focus, non-flexible adherence to specific non-functional routines or rituals, stereotypical and repetitive motor movements of the hand or finger flapping, and persistent preoccupation with parts of objects. Now, if you consider each of these 4 points with the car example, it is very easy to understand this repetitive behavior, and once we have understood this concept, I'm sure none of us will ever forget it. So I'm repeating this once more. Stereotypical restricted patterns of interest, non-flexible adherence to specific routines, stereotypical motor movements, or persistent preoccupation with parts of objects. Now, coming to the statistics, vital statistics of it, coming to prevalence, in Western countries, the prevalence is 7.1 per 10,000 under 18 years of age, with boys more affected than girls, and a male is to female ratio of almost 4:1. Now, the higher prevalence rate currently is not attributed to an increased number of cases, but rather to an increase in identification. Because all the while, diagnosis is itself a stigma, and people do not want to come forward for screening, and it tends to get neglected. Now, within Indian context, there is very limited data available, and diagnosis is frequently missed because of the social stigma. However, an increasing trend of awareness and knowledge among health professionals and an increase in general educational level of the general public has increased in an increased amount of awareness, and as a result of which studies which have been published from Delhi and Chandigarh have shown that the incidence of autism is also increasing in India as well. Now, as far as the cause, no single unified theory can explain the etiology of autism. Nobody can say that it is because of a cause and effect relationship. There is a causative factor X and Y. As a result of X and Y in that individual, in that child, there is a presence of autism. It doesn't work that way. The general perception is autism is genetic, and studies have proven that. However, as long as there is an environment, there is also an environmental factor to play. Now, the presence of those genes make the individual more prone for autism, but the environment in which that individual is present has a role as far as the expression of the genes are concerned at that appropriate age. Structural MRI studies of the brain have shown an increased volume of the total brain, certain abnormalities of the cerebellum, frontal lobe, as well as the limbic system in young children with autism, where the investigation has been done. Now, as far as how early we can diagnose autism, as early as possible would be great and would go a long way in helping the child to come forward. But within the first year of life, it is very difficult to identify because of the developing milestones, and there are no clear discriminating features within the first 1 year of life. However, now with the advent of smartphone, parents do have a habit of taking videos of their children, and these home videos do tend to be proof of certain points which tend to be missed out by the parent, like not showing objects, not looking at others, failing to be oriented to call, somewhat of an attention span deficit as well. All do play a role. But these home videos do act as a tool for developmental screening as well. It is interesting to note that there is an abnormally accelerated rate of the growth of the head size between the 6th and the 14th month of age, which is an early warning sign for the risk of autism. Now, we do tend to attribute neurodevelopmental disorders to microcephaly and to abnormally small head size or failure of growth of head circumference at subsequent follow-ups. But autism characteristically is associated with an abnormally accelerated rate of growth of the head size. It's a warning signal. It is not seen in all children. I'm stressing upon this. It is not seen in all children, but is seen in many. Now, when I say early diagnosis is important, parental concerns must be given attention. It should not be neglected. And with a reasonable degree of reliability, autism can be successfully diagnosed by the second to third year of life. Now, intervention therapy can be initiated early on, as soon as possible, and does help in the overall outcome. And it is important to give parental counseling regarding the recurrence risks. Now, when I say alerting signals in children between the age group of 2 to 3, the social impairments which are alert signs are failure to imitate actions such as clapping, does not show toys to others, lack of interest in playing with other children, indifferent to people's emotion. Example, when the mother cries, it is a natural response for the child to cry. If the child sees some mother crying and does not respond to that, then it is definitely a warning sign. Tending to be alone, avoiding eye contact, preferring solitary play, not mingling with other children, or relationships with other adults, either too friendly with everyone or ignoring too much of others, and inability to develop social skills. All of these are 9 characteristic social impairments which are warning signs. Now coming to communication impairments. Inability of babbling by 12 months. Inability to speak single words by 18 months. Inability to have 2 spontaneous phrases by 24 months. Poor response to name, which might often be confused with deafness. Delayed language development, especially comprehension. Unusual use of language. Now, when I say unusual use of language, repetitive phrases in place of normal response. Deficiency of non-verbal communication, that is, absence of hand gestures. Inability to participate in shared imaginary games, or that is, appropriate nursery games for that age, or inability of having requisite language for that age, or developing loss of any language skills at any given point of time, or communication warning signs. Now, coming to the warning signs as far as the behavioral patterns are concerned, any child who resists a change in the routine, inappropriate attachment to objects, could be as simple as having undue affection towards a teddy bear and holding onto that teddy bear all day long. Inability to cope with change, especially in an unstructured setting. Good example of that is uncontrollably crying while taken for the first time to a beach, where there is no aspect of giving any undue fear. Repeated motor mannerisms such as hand flapping or rocking, or repetitive play with toys, the example of the car which I had showed. Without purpose switching a light on and off, irrespective of being reprimanded to do so, not as an experimental play. Oversensitive towards sound or touch. A child which is overly aggressive towards his peers with the habit of biting or attempting to hit the fellow children. Or inappropriate situations where the child ends up crying, laughing, or showing distress for no apparent reason, all of which are alert signals in that age group. Now, when we move on to a slightly older age group, the social impairments include inability to join the play of other children cooperatively in a group, inability to maintain certain classroom norms, inability to follow the current trends which is expected for that children, inability for the child to be overwhelmed by social stimulation, that is, crowd phobia, though it can be normal to an extent. Undue crowd phobia is a warning sign, and failure to relate normally to other adults, that is either too intense or no relationship at all with either the teacher or the parents at home. Now, communication impairments include, I'm telling this with regard to the primary school age. Speaking in a monotonous tone without voice modulation, without emotions. Persistent echolalia, that is, echolalia being repetitive use of the same word again and again. Referring to the child self as you, she, or he rather than I or by name. This is often the most characteristically identified point with which we do tend to see children. Unusual vocabulary for the child's age or social group. Now, here I am going into the spectrum of being able to tell more for age. That is, being able to, example, name all the capital cities of all countries, or knowing the name of all world currencies, or all the state capitals of India. This is not expected for a child who is in preschool or in primary school. So it is definitely an alert sign. Apart from that, limited use of language for communication, like I mentioned, might be mistaken to be deaf or mute, and tendency to talk freely but very specifically about specific topics, example, car models. And as far as behavioral patterns are concerned, extreme reactions towards invasion of personal space, that is the undue showing of temper tantrums, extreme resistance when hurried for a particular task, wanting to watch a same educational video or any other video repeatedly, borderline addiction, intense interest in a particular topic such as train timetables, flights, a particular YouTube video, or dinosaurs, etc., unable to cope with change in an unstructured situation or unusual response to a particular stimuli such as sunlight. I'll just briefly mention about the screening tools because it is just with the intention of sensitization. So apart from the DSM-5 criteria, we have the MCHAT. MCHAT is nothing but the modified checklist for autism in toddlers. This is very widely used and is easily implementable. Apart from that, we have PDDBI, which is Pervasive Developmental Disorders Behavior Inventory. ADIR, which is Autism Diagnostic Interview Revised. ADOS, which is Autism Diagnostic Observation Schedule. CARS, which is an acronym for Childhood Autism Rating Scale, and Trivandrum Autism Behavioral Checklist. Now, all of these are screening tools. Each of them has its own advantages and disadvantages. But if you had to choose one, MCHAT would be the screening tool of choice. Now, comorbid conditions in autism, apart from autism per se, include mental retardation seen in almost 3/4 of all children. Around 10% have associated epilepsy or other neurological signs. These children do tend to have behavioral disturbances such as self-injurious behavior, aggression, hyperactivity, and temper tantrums as well. And syndromic involvement include Fragile X syndrome, phenylketonuria, and congenital rubella syndrome. Now, the spectrum of pervasive developmental disorders comprises this entire spectrum: autism, Asperger's syndrome, Rett syndrome, childhood integrative disorder, and PDD. NOS stands for no specific etiology. So, all of these together is a spectrum. You cannot really look at any one in its own, and it must be considered as a spectrum disorder. That is why I am stressing upon this again. Autism is a spectrum disorder. Now, management-wise, it requires a multidisciplinary approach involving a developmental pediatrician, a child psychiatrist, behavioral therapist, speech therapist, psychologist, specialist worker, and social worker. Now, coming to the intervention strategies, you do require pharmacotherapy, sensory integration, auditory integration, diet therapy, vitamin therapy, behavioral modification, and behavioral analysis, all combined. Now, in an initial assessment, history is the most important thing. We require as much evidence as possible. This includes the concept of home videos like I mentioned. And a detailed examination of all systems, including eyes and audiometry assessment is a must. EEG is not routinely required but may be done if subtle symptoms such as seizures are associated. And routine blood investigations such as CBC and peripheral smear must be done to rule out anemia and other disorders such as short-term infections. We always do advise for early intensive behavioral modification because there is no definitive cure for autism. It only has supportive therapy because of early intensive behavioral modification and requires 15 to 25 hours per week of playtime with the child. Now, playtime with the child is coming down these days because of a large amount of working parents and because of an increased addiction towards cell phone screens as well as computers. When I say 15 to 25 hours per week, it must be a face-to-face physical interaction and cannot be replicated online. Now, these interventions are to be continued for at least 3 to 4 years till the child's ability to learn improves and is educated. It is important to note that autism is not a disease of an infectious etiology where you have a set antibiotic to be given at a set dose at a set time per day. Every autistic child is unique and these interventions are highly individualized. Now, the skills which are taught in small steps, mastered and subsequently generalized. Now, a good example for a behavioral therapy is for a child who is not responsive. Initially, the mother will ask the child to bring a pen and every time he brings a pen to clap. Now, 2-3 times it might work, but the child will not sense a purpose in that act. So, the effectiveness of that behavior might come down. Whereas, if the mother tells a child to bring a spoon, every time he brings a spoon, if the mother feeds with a spoon of sugar or with a particular good dish, the child will correlate that act of bringing the spoon with a reward to the child which is of purpose, and hence that positive reinforcement can be used to teach the child. This example is a very simple example to understand the meaning of positive reinforcement. Now, parents can also generalize these skills which are learned by the child to the home environment to what is culturally acceptable, and non-mentally retarded children who experience difficulties in regular schools might require special schools to catch up and eventually can be brought to mainstream. Now, as far as the psychotropic medications are concerned, as far as possible, we should keep it to a minimum and avoid it if totally possible. If required, there are atypical antipsychotics which can be given at various spectrum, and there are also SSRIs which can be given for anxiety and repetitive behaviors. Methylphenidate is a psychostimulant, and opioid antagonist naltrexone can be given for hyperactivity, and symptomatic epilepsy and seizures do need to be treated accordingly depending on the seizure type. As far as all the psychotropic medications are concerned, it is only a as I was saying, it is only a second line therapy. And as a second line therapy, it is only for supportive measure but cannot replace the face-to-face interaction of a parent with a child. Now, this slide, autism, can also be expanded into always unique, totally interesting, sometimes mysterious. Like I mentioned, Autism Awareness Month is the month of April, which also coincides with the month in which I am recording this video. April 2nd is Autism Awareness Day, and the theme for 2020 is Spread Kindness. So as far as this message is concerned, we should try to be kind and empathetic towards any child with autism or to any parents with autistic children. Autism is definitely curable. There is no definitive cure, but early interventions do help in improving the outcome of autism. And as far as bringing these children mainstream is concerned, it requires an extra amount of special affection and care, and requires individualized attention and an individualized approach. On that note, I thank the Indian Academy of Pediatricians for making these slides available for general access, and I thank the IAP for all the work what is going on in this field. This presentation was mainly intended towards medical students from a slightly theoretical perspective, but also in a more general approach can help parents as well from an awareness perspective. If you feel based on this presentation that your child has any of the symptoms, I strongly recommend that you do visit your child's pediatrician for further screening. The diagnosis of autism or the diagnosis of any disorder is best made by a qualified medical practitioner and cannot be self-diagnosed. Now, as much as Google and these presentations do help in overall diagnosis and overall awareness, it cannot replicate the knowledge of a qualified practitioner as far as an individual patient or a child is concerned. On that note, I thank you for your kind and patient listening and hope you tune into the next video. Thank you.